In an attempt to cut down the length of these recordings, I've broken anemias into 3 sections. This is the second section and will include megaloblastic through hemolytic anemias. Megaloblastic anemias are a group of disorders caused by impaired DNA synthesis and characterized by the presence of large red blood cells. When DNA synthesis is impaired, defective red blood cell maturation results. These red blood cells are large and abnormal and are referred to as megaloblasts. Macrocytic red blood cells are easily destroyed because they have fragile cell membranes. Although the overwhelming majority of megaloblastic anemias result from cobalamin and folic acid deficiencies, this type of red blood cell deformity can also occur from suppression of DNA synthesis by drugs, inborn errors of cobalamin and folic acid metabolism, and erythroleukemia, or malignant blood disorders characterized by the proliferation of erythropoietic cells in the bone marrow. Intrinsic factor is a protein secreted by the parietal cells of the gastric mucosa. IF is required for cobalamin absorption in the distal ileum. If IF is not secreted, cobalamin will not be absorbed. Cobalamin deficiency is a vitamin B12 deficiency. Cobalamin deficiency is most commonly caused by pernicious anemia, which results in poor cobalamin absorption through the GI tract. In pernicious anemia, the gastric mucosa is not secreting IF because of either gastric mucosal atrophy or autoimmune destruction of parietal cells. In the autoimmune process, antibodies are directed against the gastric parietal cells and/or intrinsic factor itself. Because parietal cells also secrete hydrochloric acid, in pernicious anemia there is a decrease in the HCl in the stomach. An acid environment in the stomach is required for the secretion of intrinsic factor. Pernicious anemia is a disease of insidious onset that begins in middle age or later, usually after 40, with 60 years being the most common age at diagnosis. Pernicious anemia occurs frequently in persons of Northern European ancestry, particularly Scandinavians and African Americans. In African Americans, the disease tends to begin early, occurs with higher frequency in women, and is often severe. Parenteral or intranasal administration of cobalamin is the treatment of choice. Cobalamin deficiency can also occur in patients who have had GI surgery, such as gastrectomy, gastric bypass, small bowel resection involving the ileum, and chronic diseases of the GI tract such as Crohn's, ileitis, celiac disease, diverticuli of the small intestine, and chronic atrophic gastritis. In these cases, cobalamin deficiency results from the loss of intrinsic factor secreting gastric mucosal cells or impaired absorption of cobalamin in the distal ileum. Because cobalamin deficiency-related anemia has an insidious onset, it may take several months for these manifestations to develop. Laboratory data reflective of cobalamin deficiency anemia are presented in Table 31.6. Abnormal red cells are susceptible to erythrocyte destruction. A serum test for anti-IF antibodies may be done that is specific for pernicious anemia. The potential for gastric cancer is increased in patients with pernicious anemia. And testing of serum methylmalonic acid, MMA, which is elevated mainly in cobalamin deficiency, and serum homocysteine, which is elevated in both cobalamin and folic acid deficiencies, can also be done. Increasing the dietary cobalamin does not correct this anemia if intrinsic factor is lacking or if there is impaired absorption in the ileum. However, good nutrition should still be taught. The dosage and frequency of cobalamin administration may vary. A typical schedule consists of 1,000 milligrams of cobalamin IM daily for 2 weeks, and then weekly until the hemoglobin is normal, then monthly for life. High-dose oral cobalamin and sublingual cobalamin are also available for those in whom GI absorption is intact. Folic acid deficiency develops insidiously, and the patient's symptoms may be attributed to other coexisting problems such as cirrhosis or esophageal varices. GI disturbances include dyspepsia and a smooth, beefy red tongue. Common causes of folic acid deficiency include dietary deficiency, malabsorption syndromes, drugs, increased requirements of folic acid, alcohol abuse and anorexia, loss during hemodialysis. Other common causes of folic acid deficiencies are listed in Table 31.8. The diagnostic finding for folic acid deficiency are presented in Table 31.6. Also, during diagnostic studies, the gastric analysis is positive for hydrochloric acid. Replacement therapy is the treatment of choice. In malabsorption states or with chronic alcoholism, up to 5 milligrams a day may be required. Duration of treatment depends on the reason for the deficiency. Table 31.5 lists foods high in folic acid. Nursing and collaborative management include early detection and treatment, ensuring safety, focusing on compliance with treatment, and regular screening for gastric cancer. Patients with a family history of pernicious anemia should be evaluated for symptoms because there is a familial predisposition for it. Although it can't be prevented, early detection and treatment can lead to reversal of symptoms. The nursing measures presented in the nursing care plan for the patient with anemia, which is NCP 31.1, are appropriate for the patient with cobalamin or folic acid deficiency anemia. Carefully assess for neurologic difficulties that were not fully corrected by adequate replacement therapy. Protect the patient from falling, burns, and trauma. Evaluate the patient's skin at frequent intervals to detect redness if heat therapy is required. The potential for gastric cancer may be increased in patients with atrophic gastritis-related pernicious anemias. Let's discuss this question. At an outpatient clinic, KL's 78-year-old grandma is found to have a hemoglobin of 8.7 and a hematocrit of 35. Based on the most common cause of these findings in the older adult, the nurse collects information regarding what? A history of jaundice and black tarry stools, a 3-day diet recall of the foods the patient's eaten, any drugs that have depressed the function of the bone marrow, or a history of any chronic diseases such as cancer or renal disease. The correct answer would be D. Anemia in the older adult population is commonly caused by comorbid conditions such as cancer or renal disease. The anemia of chronic disease is also considered anemia of inflammation, which is caused by chronic inflammation, autoimmune and infectious disorders such as HIV, hepatitis, or malaria, heart failure, malignant diseases, or bleeding episodes. It's associated with the underproduction of red blood cells, mild shortening of red blood cell survival, and usually there's a mild anemia but can become severe if the underlying disorder is untreated. This type of anemia, which usually develops after 1 to 2 months of disease activity, has an immune basis. The anemia of chronic disease is depicted in this graphic. The cytokines released in these conditions, particularly interleukin-6, cause an increased uptake and retention of iron with macrophages. This leads to the diversion of iron from circulation into storage sites with subsequent limited iron available for erythropoiesis. There is also reduced red blood cell lifespan, suppressed production of erythropoietin, and an ineffective bone marrow response to the erythropoietin itself. For any chronic disease, there may also be additional factors contributing to the anemia. For example, with renal disease, the primary factor causing anemia is decreased erythropoietin, a hormone made in the kidneys that stimulates erythropoiesis. With impaired renal function, erythropoietin production is decreased. Anemia of chronic disease must first be recognized and differentiated from anemia of other etiologies. Elevated serum ferritin and increased iron stores distinguish it from iron deficiency anemia. Normal folate and cobalamin blood levels distinguish it from those types of anemias. The best treatment of anemia of chronic disease is correction of the underlying disorder. If the anemia is severe, blood transfusions may be indicated, but they are not recommended for long-term treatment. Erythropoietin therapy with epigen or darbepoetin is used for anemia related to renal disease and may be used for anemia related to cancer and its therapies. However, it needs to be used conservatively as there is an increased risk of thromboembolism and mortality in some patients. We'll move on to aplastic anemia. Aplastic anemia is a disease in which the patient has peripheral blood pancytopenia, which is a decrease in all blood cell types. The spectrum of the anemia can range from a chronic condition managed with erythropoietin or blood transfusions to a critical condition with hemorrhage and sepsis. Approximately 75% of the acquired aplastic anemias are idiopathic and are thought to have an autoimmune basis. The patient with neutropenia, or low neutrophil count, is susceptible to infection and is at risk for septic shock and death. Even a low-grade temperature below 100 should be considered a medical emergency. Thrombocytopenia is manifested by a predisposition to bleeding evidenced by petechiae, ecchymosis, and epistaxis. All marrow elements are affected in this disorder. The condition is classified as normocytic, normochromic anemia because although hemoglobin, white cell, and platelet values are decreased, other red blood cell indices are generally normal. Aplastic anemia can be further evaluated by assessing various iron studies. The serum iron and total iron binding capacity may be elevated as initial signs of erythropoiesis suppression. Bone marrow biopsy, aspiration, and pathologic examination may be done for any anemic state. However, the findings are especially important in the aplastic anemia patient because the bone marrow is hypocellular with increased yellow marrow or increased fat content. In the management of aplastic anemia, we'll identify and remove the causative agent if that's possible, provide supportive care until the pancytopenia reverses, prevent complications from infection, and prevent hemorrhage. The prognosis of severe untreated aplastic anemia is poor, but advances in medical management, including hemopoietic stem cell transplant and immunosuppressive therapy with antithymocyte globulin, ATG, and cyclosporin or high-dose cyclophosphamide, or Cytoxan, have improved outcomes significantly. ATG is a horse serum that contains polyclonal antibodies against human T cells. It can cause anaphylaxis and a serum sickness. The rationale for this therapy is that idiopathic aplastic anemia is considered an autoimmune disorder resulting from activated cytotoxic T cells that target and destroy the patient's own hematopoietic stem cells. The treatment of choice for adults less than 55 years of age who do not respond to immunosuppressive therapy and who have an HLA-matched donor is human stem cell transplant therapy. The best results occur in younger patients who have not had previous blood transfusions. Prior transfusions increase the risk of graft rejection. For older adults without an HLA-matched donor, the treatment of choice is immunosuppression with ATG or cyclosporin or high-dose cyclophosphamide. High-dose corticosteroids may also be used, however, this therapy may be only partially beneficial. Patients who need ongoing support with blood transfusions should be on an iron-binding agent to prevent iron overload. Anemia resulting from blood loss may be caused by either acute or chronic problems. Acute problems such as sudden hemorrhage or chronic loss similar to those of iron deficiency anemia. Acute blood loss caused by sudden hemorrhage may result from trauma, complications of surgery, or conditions or diseases that disrupt vascular integrity such as hypovolemic shock or compensatory increased plasma volume with diminished oxygen-carrying red cells. Clinical concerns result from either a sudden reduction in the total blood volume that can lead to hypovolemic shock, or if the acute blood loss is more gradual, the body maintains its blood volume by slowly increasing the plasma volume, but then the number of red cells is significantly diminished. Table 3110 summarizes the clinical manifestations of patients with varying degrees of blood volume loss. It's essential to understand that the clinical signs and symptoms that the patient is experiencing are more important than the lab values. For example, an adult with a bleeding peptic ulcer who had a 750 milliliter hematemesis, which is 15% of the normal total blood volume, within the past 30 minutes may have postural hypotension, but may have normal values for H and H. Over the ensuing 36 to 48 hours, most of the blood volume deficit will be replaced by the movement of fluid from the extravascular into the intravascular space. Only at these latter times will the H and H reflect the blood loss. Assess the patient's expression of pain. Internal hemorrhage may cause tissue distension, organ displacement, and nerve compression. Internal hemorrhage may also cause pain that is localized or referred. In the case of retroperitoneal bleeding, the patient may not experience abdominal pain. Instead, the patient may have numbness and pain in the lower extremity, secondary to compression of the lateral cutaneous nerve, which is located in the region of the first to third lumbar vertebrae. Shock is the major complication of acute blood loss. With sudden blood volume loss, values may seem normal or high for 2 or 3 days. Once the blood volume has been replaced, the red blood cell mass will be less concentrated. Then the red blood cell, hemoglobin, and hematocrit levels are low and reflect the actual blood loss. IV fluids used in emergencies include dextran, hetastarch, albumin, and/or crystalloid electrolyte solutions such as lactated ringers. Amounts vary with the solution. Once volume replacement is established, attention can be directed to correcting the red cell loss. The body needs 2 to 5 days to manufacture more red cells in response to increased erythropoietin. Consequently, blood transfusions may be needed if the blood loss is significant. If the bleeding is related to platelet or clotting disorders, replacement of that deficiency is addressed. The patient may also need supplemental iron because the availability of iron affects the marrow production of erythrocytes. When anemia exists after acute blood loss, dietary sources of iron will probably not be adequate to maintain iron stores. Therefore, oral or parenteral iron preparations are administered. It may be impossible to prevent acute blood loss if it's caused by trauma. In postoperative patients, you want to monitor for any blood loss and administer blood products for any anemia. There is no need for long-term treatment for this, and the anemia should begin to correct itself once the source of hemorrhage is identified, blood loss is controlled, and the fluid and blood volumes are replaced. The source of chronic blood losses are similar to those of iron deficiency anemia. The effects of chronic blood loss usually are related to the depletion of iron stores and are considered as iron deficiency anemia. Hemolytic anemia is the destruction or hemolysis of red blood cells at a rate that exceeds production. It's caused by problems either intrinsic or extrinsic to the red blood cells. Intrinsic forms are usually hereditary and result from defects in the red blood cells themselves. Red cells are normal in acquired forms, which are more common. Damages caused by external factors. The sequence of events in hemolysis in extrinsic hemolysis, the spleen is the primary site of the destruction of red blood cells that are old, defective, or moderately damaged. Jaundice is likely because of the increased destruction of red blood cells causing an elevation in bilirubin levels. The spleen and liver may enlarge because of their hyperactivity, which is related to macrophage phagocytosis and of the defective erythrocytes. Maintaining renal function in hemolysis is a priority because when red blood cells are hemolyzed, the hemoglobin molecule is released and filtered by the kidneys. The accumulation of hemoglobin molecules can obstruct the renal tubules and lead to acute tubular necrosis.